RGHS anatomy of ear. In RS2 and RS3, the anatomy of middle ear cleft has been asked as 10-mark question and 5-mark question frequently. And also the normal tympanic membrane with diagram has been asked 2 to 3 times as short essay. Following that, the pinna nerve supply, McEwen's triangle, tympanic membrane, nerve supply of external auditory canal, and mastoid air cell system, and also tympanic plexus has been asked as 3 markers. We will discuss all of this shortly. In RS4, only tympanic membrane was asked as a short essay, but we can expect the examiner to ask middle ear and any other questions which I mentioned earlier. Now, what are the parts of ear? The ear is divided into 3 parts: external ear, middle ear, and inner ear. The external ear consists of pinna and external auditory canal, and also the tympanic membrane. The middle ear consists of middle ear cleft and also the mastoid head system and the connecting tube to the eustachian, to the posterior nasopharynx, the eustachian tube. These are all the parts of middle ear. The inner ear consists of bony labyrinth and membranous labyrinth. The bony labyrinth has 2 parts, that is semicircular canal and cochlea. Semicircular canal and bony labyrinth surrounding the cochlea. What are the parts of membranous labyrinth? The membranous labyrinth has cochlear duct. This membranous labyrinth lies and inside this bony labyrinth. So inside this cochlear tongue, we have cochlear duct. We have utricle saccule and also 3 semicircular canals. Connecting saccule and semicircular canal, we have endolymphatic duct and endolymphatic sac. We will discuss about this endolymphatic duct sac when we discuss Meniere's disease. And also, since anatomy of inner ear has not been asked in RGHS much, so we are skipping the discussion about inner ear. We are proceeding on with tympanic membrane. What are the parts of tympanic membrane? The tympanic membrane has pars tensa, flaccida, the annulus. I'll explain each of them shortly. Before that, the tympanic membrane is 9 to 10 mm tall, 9 to 10 mm tall, 8 to 9 mm wide, and the thickness of tympanic membrane is 0.1 mm. Please note this because it's asked in Viva. I mentioned this. The tympanic membrane is 8 to 10 mm long, followed by 9 to 10 mm long, followed by 8 to 9 mm wideness, and then the thickness is 0.1 mm. Then let's discuss about pars tensa. What is pars tensa? The pars tensa, as you can see, it forms the most part of tympanic membrane. The periphery of pars tensa form a fibrocartilaginous ring called as annulus tympanicus. The periphery of the pars tensa is forming the fibrocartilaginous ring called as annulus tympanicus. This annulus tympanicus is very, very important because while discussing about CSOM, we will get to know the CSOM, the central perforation, marginal perforation are defined based on the involvement of annulus tympanicus. The central part of pars tensa is tented inwards at the level of tip of malleus. This is called as umbo. And also you can see the bright radiating cone of light in the antero-inferior quadrant of tympanic membrane. So now we discussed about pars tensa, the fibrocartilaginous thickening called as annulus tympanicus, the central bulge inwards called as umbo, and also antero-inferior quadrant we see cone of light. Let's see what is pars flaccida or Sharpnell's membrane. Flaccida. The pars flaccida, as you can see, it's situated above the lateral process of malleus and between the notch of Rivinus and anterior and posterior malleolar fold. Here you can see this is the notch of Rivinus where our annulus tympanicus lies. This is the anterior malleolar fold. This is the posterior malleolar fold. In between these structures, we see pars flaccida. It is not so taut as pars tensa, but may appear slightly pinkish. Then we have layers of tympanic membrane. What we discussed now? We discussed pars tensa and pars flaccida, and the parts of it, the boundaries of it. What are the layers of tympanic membrane? Layers. Characteristically, from outside inwards, there are three layers of tympanic membrane. Those are outer epithelial layer, which is continuous with the skin lining the meatus. And then we have inner middle fibrous layer, followed by inner mucosal layer, which is continuous with mucosa of middle ear. So we saw the outer epithelium, outer layer is continuous with the epithelium of external aortic canal, which is stratified squamous keratinized epithelium. The middle layer is fibrous layer and the inner layer is mucus layer, which is continuous with mucosa of middle ear. The middle layer, fibrous layer, has three types of fibers. Those are radial, circular, and parabolic. Radial, circular, and parabolic. These are the three types of fibers which is in middle fibers layer of tympanic membrane. Now, if it asks as 5-mark question, please mention relations of, no, not relations. Tympanic membrane is done now. We saw the tympanic membrane, pars tensa, pars flaccida. In pars tensa, cone of light, umbo, and then annulus tympanicus. The pars flaccida, which is bounded anteriorly by anterior malleolar fold, posteriorly by posterior malleolar fold, and below by lateral process of malleus, and above by notch of Rivinus. The three layers of tympanic membrane: outer epithelium, middle fibers, and inner mucus layer. Please learn the diagram of tympanic membrane. It's very important. It's as a 3-mark and 5-mark question. Also, if it's as a 5-mark question, please mention the nerve supply of tympanic membrane. The nerve supply of tympanic membrane is anterior of lateral surface is supplied by V3, auriculotemporal nerve. Anterior of lateral surface is supplied by V3, auriculotemporal nerve. The posterior of lateral surface is supplied by auricular branch of vagus, 10th nerve. And the medial surface is supplied by tympanic branch of 9th nerve, that is Jacobson's nerve. This is about tympanic membrane. I hope all of you understood. Let's proceed on to the next topic of discussion, that is middle ear. Before that, I will mention the nerve supply of pinna, which is asked as 3 marks question frequently. The pinna, which is the part of external ear, has helix, antihelix, symba concha, tragus, antitragus, and all. You please go through it once. Coming to nerve supply of pinna, very important question. Pinna, The anterior part is supplied by auriculotemporal nerve. Matching with this, the anterior half of lateral surface of tympanic membrane is also supplied by auriculotemporal nerve. The posterior part, posterior two-third of pinna is supplied by greater auricular nerve C2, C3. The anterosuperior part of pinna is supplied by 10th nerve, 7th nerve and 10th nerve. This point is important. It comes handy while we are discussing the acoustic neuroma, where we see the hypostasia in the posterior superior part of the external auditory canal due to the involvement of 7th nerve, that is facial nerve. This is about the nerve supply of lateral surface of pinna. Now coming on to nerve supply of medial surface of pinna. The upper part is supplied by lesser occipital nerve, the lower part by greater auricular nerve, and the posterior part of medial surface is supplied by 7th nerve and 10th nerve. Here you see the greater auricular nerve supplying the posterior part of lateral surface continues posteriorly to supply the anterior part of medial supply, anterior part of pinna, medial surface of pinna. Along with C2, C3 greater auricular nerve, the lesser occipital nerves joins here. And also please note the cranial nerve supplying the external auditory canal posterior superior part, correspondingly posteriorly it goes and supply posterior aspect of medial surface of pinna. Let me clarify this once more. The nerve supply of pinna, the lateral surface, we have medial surface. In the lateral surface, the anterior part is supplied by auriculotemporal nerve V3, which is a branch of trigeminal nerve. The posterior aspect is supplied by greater auricular nerve C2, C3. The posterior superior part of external auditory canal is supplied by 7th nerve and 10th nerve. This greater auricular nerve C2, C3 continues backwards to supply the anterior part of medial surface of pinna. And then above that, our lesser occipital nerve joins here to supply the upper part of medial surface of pinna. This posterior superior part supplying 7th and 10th nerve will supply the posterior aspect of medial surface of pinna. I hope the nerve supply of pinna is clear to you. I'll pause for 10 minutes, 10 seconds. If anyone has doubt, let me clarify. Please unmute yourself and ask the question.
Clear.
Okay, then we'll proceed on to the next most important topic, that is middle ear. Before that, in Viva and all, our questioner asked what is middle ear cleft as a first question. Middle ear cleft is eustachian tube, the middle ear, and the mastoid air cells. From anterior to posterior, combining eustachian tube, middle ear, and the mastoid air cells along with adductus ad antrum, we call it as middle ear cleft. Now the middle ear is lined by mucous membrane and it's filled by air. We all know that. Please note, the middle ear extends beyond the limits of tympanic membrane, which forms the lateral boundary, and is sometimes divided into mesotympanum, epitympanum, and hypotympanum. What's the meaning? Here you can see This is tympanic membrane. The middle ear extends beyond the tympanic membrane upwards and downwards. The part corresponding to tympanic membrane is called mesotympanum. The part above the tympanic membrane is called epitympanum, and the part below the tympanic membrane is called hypotympanum. The portion of ear around the tympanic orifice of eustachian tube is sometimes called as protympanum, but yes, here anteriorly we know in the anterior wall we have the opening for eustachian tube. The surrounding part of middle ear surrounding the opening of eustachian tube is called as protympanum. In the middle ear we have imagine middle ear as a room which has roof, which has been removed here. Floor also has been destroyed. The anterior wall, the lateral wall, posterior wall, and the medial wall. Middle ear is a room which has roof, floor, anterior wall, posterior wall, lateral wall, and a medial wall. Now, what are the things that we see in anterior wall? Anterior wall has a thin plate of bone which separates the cavity from the internal carotid artery. Very, very important. Anterior wall has a thin plate of bone which separates the middle ear from the internal carotid artery. It has two openings, lower one for eustachian tube and the upper one is for tensor tympanic muscles which goes and attach to the lateral process of malleus. What about posterior wall? The posterior wall lies close to the mastoid hair cells. We all know that it presents a bony projection called as pyramid, the summit of which appears our stapedial tendon, which attaches to the stapes and is responsible for stapedial reflex and protection of our inner ear. We'll discuss about the stapedial reflex afterwards. The aditas, it's an opening through which the attic, that is middle ear, communicates with the antrum. It lies above the pyramid. So, the opening from attic, that is middle ear cavity, to the mastoid is called aditas ad antrum, which lies just above the. Sorry, this is whole window. I am not mentioning it. I think this is not. Aditas ad antrum is not given in this question. Sorry for marking wrong structures here. So above the pyramid, we have an opening called aditas ad antrum, which connects the middle ear cavity with the mastoid air cells. Surgically, we have facial recess in posterior wall, which is surgically important, as the direct access can be made through into the middle ear without disturbing posterior canal, which is also the important route of insertion of electrode of cochlear implant. Okay. What is facial recess? Facial recess or the posterior signs the depression in the posterior wall lateral to the pyramid. So lateral to the pyramid in the posterior wall, lateral to the pyramid, we have a depression called as facial recess. It is the site for access of surgery without disturbing the posterior canal, and also we can insert the cochlear implant through that facial recess. Here in this image, I am not able to show facial recess. So let's continue with the lateral wall. The lateral wall is formed largely by the tympanic membrane. We all know that, and the lesser extent by the bony outer attic, the sputum. The tympanic membrane is semi-transparent and forms a window into the middle ear. We all know that. It is possible to see some structures in the middle ear through the normal tympanic membrane, the long process of incus, incoestophageal joint, and the round window. This is lateral wall. In the lateral wall, we have the maximum part that is bounded by tympanic membrane. We have the chorda tympani, the branch of facial nerve running medial to the tympanic membrane in the middle ear. And also we can see the projection of long process of incus. Also we can see lateral process of malleus through the tympanic membrane while we do examination. Now we discussed about anterior wall, posterior wall, and lateral wall. In anterior wall, we have the opening for tensor tympani tendon and the opening for eustachian tube, and also we have the thin bone which is separating anterior wall from the internal carotid artery. We saw the posterior wall which houses the pyramid, the summit of which there is attachment of stapedius tendon. We have the facial vertical part of facial nerve running through the posterior canal, and also we have facial recess just lateral to the pyramid, which is the site of access for surgery and also the site where we can pass through the cochlear implant. And also we saw lateral wall where we can see the tympanic membrane and then chorda tympanic nerve, the projection of incus, and lateral process of malleus. This is about the anterior, posterior, and lateral wall. Let's see the most important among these walls, that is medial wall of middle ear. The medial wall of middle ear is formed by labyrinth. You all know. The labyrinth projects as bulge in the middle ear, which is called as promontory. Bulge in the middle ear called as promontory. It's not shown in this image. Let me make it. The promontory. This promontory, the projection into the middle ear, is due to the basal coil of cochlea. We saw cochlea in the bony labyrinth. The basal turn of it, here you can see the basal turn. The basal turn of it projects into the middle ear, which is called as promontory. This is promontory. On promontory, we have tympanic plexus. The oval window into which our foot plate of stapes is fixed is present above the promontory, and the round window or phonestocoine is covered by secondary tympanic membrane. It is below the oval window, that is marked as structure 4 here. This is round window. Now what is the importance of round window and oval window? Oval window, we all know the foot plate of stapes comes here. It oscillates and generates the vibrations in the endolymph, which is responsible for hearing. What is the role of round window and secondary tympanic membrane? The round window and secondary tympanic membrane provides phase difference to the middle ear. What is phase difference? Phase difference is nothing but when the foot plate of stapes goes inside through the oval window, in the round window, the secondary tympanic membrane comes out. What a beautiful mechanism. Why the oval window is going in and the secondary tympanic membrane is coming out? By single auditory stimulus. We have only one auditory stimulus. Okay, you are hearing me. The auditory stimulus is 1. Due to this auditory stimulus, the oval window is going in. Simultaneously, the round window, the secondary tympanic membrane, is coming out. Why? Because the transmission of the vibrations occur to the oval window faster than to the round window because of the middle ear ossicle, that is malleus incus stapes, which is responsible for amplification of sound. So these malleus incus stapes will transmit the sound waves faster to the oval window than the round window. How the round window picks up the vibrations. The round window picks up the vibrations through the normal air, which is coming through the electric in the sorry the impulse, the auditory impulse goes through the tympanic membrane, malleus incus stapes, to the oval window faster. Now here, in case of round window, the sound waves transmitted through the air. So while oval window, the food paste of stapes goes in, the round window comes out. So that what is the implication of this? This implies that here in the inner ear we have scala vestibuli, scala tympani, and all the air cells, the basilar membrane and all. So during oscillation, the upper part of fluid, when it goes this direction, the lower part of fluid comes in opposite direction. Thereby, the hearing mechanism is established. This is called phase difference, which is one of the important mechanism which is responsible for amplification of sound. Okay, let's continue with the topic. So in the medial wall of middle ear, we saw promontory, tympanic plexus, oval window, and round window. Now also we have above the oval window, there is a canal for facial nerve. Above the oval window, we have the canal for horizontal part of facial nerve. In some patients, it may be deficient. So during surgery, we should pay utmost attention or else we can injure it. Bony covering may be congenitally absent in some patients. So also just anterior to the oval window, in the medial wall, there is a hook-like projection called as processus cochleariformis, where our tendon coming from this tensor tympani hooks here and goes and attaches to the lateral process of malleus. Processus cochleariformis is one of the important anatomical site which helps to localize the facial nerve. So then in the medial to the pyramid is a deep recess called as sinus tympani. Medial to the pyramid, there is sinus tympani. Lateral to the pyramid, we have facial recess. Sorry, I have not put up the images because of time constraints. Please pardon me. You would have understood better about sinus tympani and facial recess if I have shown the images for you. You can Google it and see the images. So medial to this process pyramid, we have sinus tympani. Lateral to it, we have facial recess. We discussed about medial wall of middle ear. The medial wall of middle ear has promontory. The tympanic plexus processus cochleariformis, oval window, round window, horizontal part of facial nerve, and also horizontal semicircular canal. I missed this part. Sorry, horizontal semicircular canal. So we have fistula test positivity because of this. If there is any deficiency, if there is fistula in the horizontal semicircular canal, this leads to vertigo and fistula test positive. We'll discuss it later. We saw the middle ear anatomy in great detail. We discussed anterior wall, posterior wall, medial wall, and lateral wall. I am pausing for 10 seconds. If anyone has doubts, please let me know. I will try to clarify. Please unmute yourself and let me know.
No doubt, Guru. Doubt.
Okay. Before proceeding on to the mastoid antrum air cells, which is a 3-mark question, we have another 3-mark question, that is tympanic plexus. The tympanic plexus, it lies on the promontory and it's formed by tympanic branch of glossopharyngeal nerve. Please note the nerve. We have to remember the branches of nerve. It is formed by tympanic branch of glossopharyngeal nerve. Glossopharyngeal nerve. Sympathetic fibers from plexus around the internal carotid artery. We saw the internal carotid artery just lies beside the anterior wall, separated by a thin bone. The sympathetic plexus present around the internal carotid artery will also give it branches to the tympanic plexus. Sympathetic branches. The tympanic plexus supplies the innervation to the medial surface of the tympanic membrane. We already saw while discussing the nerve supply of the tympanic membrane. The nerve supply we discussed. The medial tympanic plexus supplies the medial surface of tympanic membrane, entire tympanic cavity, mastoid hair cells, and bony eustachian tube. Eustachian tube has two parts, bony and cartilaginous part. Entire middle ear cleft, that is tympanum, the medial surface of tympanic membrane. Tympanic membrane, medial surface, the entire tympanum, that is middle ear cavity, and also the bony part of eustachian tube is supplied by tympanic plexus. Also carries secretomotor fibers for the parotid gland. You can note this point. The section of tympanic branch of glossopharyngeal nerve can be carried outside the middle ear in case of Rett syndrome. Okay, let it be. The course of secretomotor fibers in parotid. This is not important. The tympanic plexus is asked as a 3-mark question. I mentioned it is formed by mainly two branches. The tympanic branch of glossopharyngeal nerve and also the sympathetic fibers around the internal carotid artery. What is the nerve supply? It supplies the medial surface of tympanic membrane, entire tympanum, that is middle ear cavity, and also bony eustachian tube. And also it gives secretomotor fibers to the parotid gland. The tympanic branch of glossopharyngeal nerve is also called as Jacobson's nerve, as in Viva. So this is about the tympanic plexus, which lies on top of promontory. Next in the discussion, we have the types of hair cells in case of mastoid antrum. Before that, let me give briefly the anatomy of mastoid system. In the mastoid system, we have adductor antrum, that is the opening of the mastoid cavity into the middle ear. The adductor antrum opens here. Now see, this is the posterior wall of middle ear. Floor, roof, let it be anterior wall. Okay. Here from the adductor antrum, we have mastoid cavity. The mastoid cavity has three types of hair cells, that is sclerotic, pneumatic, and diploic. Sclerotic type of hair cells are hair cells where there is no air inside it. The pneumatic ones has air inside it. The diploic ones has blood inside. We know the diploic, between two tables in the cranium, between the outer table and inner table of the skull, we have diploic, which is responsible for hematopoiesis. So there can be three kinds of hair cells, that is sclerotic, pneumatic, and diploic. And also we have few name cells based on the locations. The zygomatic hair cells, the periantral hair cells around the antrum, the synodural, the squamosal hair cells, which is present in the squamous part of temporal bone, perisinus hair cells, retrofacial hair cells, marginal hair cells, tip hair cells, peritubal hair cells, the petrous apex hair cells. So you just think of the anatomy, write peri and get marks. So let me summarize this for you. The mastoid hair cells, there are three types: sclerotic, pneumatic, and diploic. Sclerotic don't have hair, pneumatic has hair. Diploic one is where the hematopoiesis take place. The types of hair cells are squamosal, periantral, perisinus, retrofacial, marginal cells, tip cells, and zygomatic hair cells. You can mention 3 to 4 types of hair cells and get 3 marks. This is about the anatomy of middle ear. We have superior temporal line, and also we have superior temporal line. We have posterior superior part of external aortic canal, and also we have the tangent drawn from this line to the posterior superior part of external aortic canal. This is called as McEwen's triangle. This is important in surgery to locate mastoid antrum. As I already told, it's the area where beneath which the mastoid antrum, the biggest air cells of mastoid air cells, is present. I hope, Sahil, you understood what is McEwen's triangle. Let me summarize it once again. Superiorly, it's bounded by superior temporal line, and anteriorly by posterior superior part of external aortic canal. And then at last, we draw an imaginary tangent from superior temporal line joining the external aortic canal, posterior superior part of external aortic canal. This forms the McEwen triangle. In this McEwen triangle, beneath it lies the mastoid antrum, which is the important surgical landmark for mastoid surgery. Anatomy of ear. Second chapter, we have two important questions. Those are theories of hearing, the mechanism of hearing. The physiology and mechanism of hearing is an RS2 question you asked us a long essay. You can mention the mechanism of hearing starting from external ear to the internally and physiology. You can study this since it has only once. I am not covering it. I am now covering the important question, the impedance matching and transformer mechanism in the middle ear, theories of hearing. This is as a 3-mark question and a short essay. And then following that, we'll go for assessment of hearing. How to assess a hearing loss in OPD, which is one side as a 10-mark short essay. Tuning fork test and its significance as many times. Renus test, Pluton audiometry, tympanometry, Bera and autoacoustic emission I will not be covering. Let me put a red mark for it. Please note Bera and autoacoustic emission I am not covering only because it's asked only once. Let's discuss only the questions which are asked repeatedly. So in under 3 marks, Rennes test and clinical significance I will discuss. Weber's test I will discuss. False negative Rennes test I will discuss. Schwabach Bing test asked only once as 3 marker. You can go through it at once, or I'll mention it briefly while talking about a tuning fork test. So this is the plan for the second part of this session. Let's go. Coming on to the impedance matching or the transformer mechanism of the middle ear. The lever or action of ossicles. The handle of malleus, if you see, it is 1.3 times longer than long process of incus. The handle of malleus is 1.3 times longer than long process of incus. Since the handle of malleus is longer than long process of incus, it gives a mechanical advantage. That is when handle of malleus vibrate, there is mechanical advantage of 1.3 times while transmitting the sound from handle of malleus to the long process of incus. This is the lever action. And then we have hydraulic action of tympanic membrane. The area of tympanic membrane is much more larger than compared to small chotusa foot plate of stapes. So there is a lever action. That is, the handle of malleus is 1.3 times longer than long process of incus, giving a mechanical advantage of 1.3 times. The area of tympanic membrane is much more larger compared to foot process of stapes, giving a advantage of at a ratio of 21:1, which gives a mechanical advantage. As the effective vibratory area of tympanic membrane is only 2/3, the effective oral ratio is reduced to 14:1 than 21:1. What the textbook is telling is, see, the whole tympanic membrane is not vibratory. Pars tensa here, it is vibratory. The pars placida and other parts not pars pluribus. The other parts of tympanic membrane are not contributing for transmission of impulse. So even though the area ratio is 21:1, the effective ratio is reduced to 14:1. So the product of oral ratio and lever ratio of ossicles gives us the ratio of 18:1. And due to this lever action and the oral area ratio, there is 22 times amplification of sound. The total transformer ratio will be 22 times. I mentioned that lever action gives 1.3 times mechanical advantage. Here it gives us the 17 times advantage due to the surface area concept that I mentioned, leading on to the mechanical total transformer ratio of 22. Have phase difference, which is responsible for amplification of sound. The phase difference, all about phase difference, where when the whole window goes in, the secondary tympanic membrane comes out. When the foot pedals of stapes goes in, the secondary tympanic membrane comes out. I explained it in great detail while explaining anatomy of middle part of middle ear. These two, the phase difference and this oral ratio and lever action, helps in amplification of sound in the middle ear. This is about the amplification of sound by the middle ear. Let's proceed on to the next topic of discussion, that is theories of hearing. What are the theories of hearing? There are importantly two theories of hearing, that is resonance theory and telephone theory. Interesting, right? Telephone theory. The resonance theory tells. According to resonance theory, if a stone is struck, the structures attendant to the frequency also vibrate. The basilar membrane stretching between osseous spiral lamina and the lateral wall of cochlea has smallest width near the basal turn of cochlea, progressively increases towards the apical turn. The fibers of basal turn are also maximally tense and thus resonate in response to higher frequencies. As the length of the fiber increases towards the apex of cochlea, the lower frequencies start resonating. In other words, analysis of speech frequency occurs peripherally at the level of cochlea. What is resonance theory telling? Let me break it down for you in simple terms. The resonance theory tells that as you go from the basal turn of cochlea to the apex of cochlea, the length of hair cells increases. In the basal turn, the hair cells are taut, meaning they are thick. In the apical turn, they are long and it is thin. So, in response to higher frequencies, the basal turn hair cells will vibrate. In response to lower frequencies, the hair cells in the apex of the cochlea will vibrate, leading on to recognition of frequency at the level of cochlea. This is about resonance theory. Let's see what telephone theory has to offer to us. Telephone theory or Rutherford's theory, the cochlea simply collects the sound, converts it into an electrical signal that are transmitted through the auditory nerve to the brain where the sounds are analyzed. That is the theory of central analysis. This is linked to the model of telephone, which receives the sound or speech and converts it into electric signals which passes through the wires. Okay. We saw two theories, the resonance theory and telephone theory. The resonance theory is also called as theory of peripheral analysis. Why? because the frequency of sound is analyzed based on the movement of hair cells. If there is high frequency, the basal turn hair cells will vibrate. If there is low frequency, the hair cells at the apex will vibrate. This is what the resonance theory says. So the recognition of frequency is occurring peripherally at the cochlea. Now, what the telephone theory is telling? The telephone theory tells us that the cochlea is not responsible for recognizing frequency, boss. It is only responsible for generating electrical impulse, which is transmitted to the brain, and the brain is the boss, which is responsible for analyzing the frequency. This is the resonance theory and the central theory, which are two opposite theories. Next, we have traveling wave theory or theory of von Becksi. It is presently the most accepted theory. These are not widely accepted in today's world. Today, the widely accepted theory is traveling wave theory. What is traveling wave theory? While working on experimental models shared the sound waves traveling through the basilar membrane, these sinusoidal waves peak at specific places according to the frequency of sound. The higher ones near the base of cochlea and the lower ones near the apex. Thus, it shows tonotopic localization of the level of cochlea, and such tonotopic localization have also been demonstrated at the level of inferior colliculus, medial geniculate body, and cortex. That is, frequency analysis that takes place at the cochlea continues right up to the cortex. So, what traveling wave theory is telling, you can think traveling wave theory as the partial combination of these two, the perfect partial combination of these two. How I will explain. The traveling wave theory tells us that here in the inner ear we have basilar membrane, the tectorial membrane, the hair cells, and all. So when the sound impulse comes, there is movement of this basilar membrane. There is sinusoidal movement. What the traveling wave theory tells us the sinusoidal movement is more in basal turn in case of higher frequency. The sinusoidal movement of the basilar membrane is more in the apex if the frequency is low, of sound is low. So thereby localizing of sound is occurring at the level of cochlea. And also it goes on to tell that it not only occurs at the level of cochlea, the recognition of the amplitude, that is the frequency, also occurs at the level of inferior colliculus, also occurs at the level of cortex, geniculate body, medial geniculate body. It is a part of thalamus, and also at the cortex. In similar fashion to cochlea. The traveling wave theory is telling that not only periphery is responsible for frequency recognition, but also not solely the center, that is brain, is responsible for frequency recognition. It's the combination of these things.